Hello, everybody, and welcome to Echo Ontario Skin and Wound. My name is Dr. Gary Sibbald. I'm a dermatologist internist with an interest in wound care and education. And David?
Hi, my name is David Walker. I'm a clinical coordinator here at Echo, and my background's in kinesiology, public health, and just finished my MBA.
Okay, Tamara.
Hi, everyone. My name is Tamara. I'm a research coordinator, and I have a background in biology and anatomy.
Okay, Renika.
Hi, good afternoon. My name is Renika. I'm the project manager for Project Echo Skin and Wound.
Okay.
Hi, good afternoon. I'm Linda. I'm the administrative assistant for Project Echo. Can I ask everybody to please sign in with your full name, your profession, where you're from, and any colleagues that are joining you, please sign them in as well. Thank you very much, and don't forget to do the surveys.
Okay, and Andrew.
Hi, everybody. My name is Andrew Mohan. I'm the multimedia coordinator for Project Echo. For the territorial acknowledgement, we acknowledge that the land from which we are presenting is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We're grateful to have the opportunity to work on this land, and by doing so, give our respects to its first inhabitants.
Okay, Zhao.
Hi, my name is Sao Chang Zhao. I'm a family doctor in Mississauga, and I do wound care as well as long-term care.
Pat.
Hello, I'm Pat Coots. I am a registered nurse, so happy Nurses Week, everyone. And I work remotely with the group in Mississauga from London, Ontario.
Okay, Dale, I see you're on.
I am. Hi, everybody. My name's Dale Kalina. I am an infectious disease specialist and Chief Medical Information Officer at Brant Community Healthcare System in Brantford, and I'm joining you today from Oakville.
Okay, and let's go to Kingston.
Hi, I'm Karen Smith. I'm a rehabilitation physician here at Queen's University and Providence Care Hospital.
And hi, I'm Jolene Heil. I work as a clinical nurse specialist, and I'm an NSWAC at Providence Care and Queen's University.
Jeremy. Maybe not yet.
He was having internet problems.
Oh, yeah, he was having internet problems earlier on. Renika, you have a request for cases, and anybody that is involved in a toolkit, it is important for you to submit a case, but even for everybody else, that is part of your ECHO commitment. Renika, tell them how easy it is to do it.
Yeah, so even if you were in the previous cycle, which is leg and foot, and you didn't get a chance to submit a case then, and you would like to get a toolkit, you can still submit a case in this cycle. In addition to that, as part of your contract with ECHO, we encourage you to submit a case. So submit a case, attend the sessions, and you would see that, it is a way that you can develop your skills. You can also learn and appreciate looking at a case from the wound bed preparation paradigm. And it helps you with, we provide you the recommendations that you can take back to the care team and work with your patient. So if you have a patient that, they have a wound that it's difficult to heal, or you're having any difficulties with that patient, I've always included the case report form in my email. So you just need to fill out the information on that form, send it back to us with any labs and any photos of related to the case, and then we will prepare the PowerPoints. So the PowerPoints that you see, the case presentations, we do that. You don't have to do it. And we will go back and forth with you, help you get all the information that you need. And then on the day of the presentation, you present the case, and we're here to guide you and help you along the way. So if you have a case, you have a patient that you're having difficulty with, or even an interesting case that you would like to share with everyone, please reach out to Linda or myself, and we will help you with the case presentation.
Okay, so today's didactic inflammatory wounds, and we will look at some of the things that are a little bit less common, but important for you to recognize. And on the next slide, We're going to review diagnostic criteria for blistering. A papule is a raised solid area less than a centimeter, a plaque greater than a centimeter, and an ulcer is the loss of epidermis with the dermal or deeper base. We're going to look at testing, differential diagnosis, and treatment options. Next one. What do you think this is? Pyoderma gangrenosum, bullous pemphigoid, hypertensive ischemic ulcer, vasculitis, or necrotizing fasciitis? And I think it's always important that if you're not sure what something is, to at least measure it, state the location, and use the clinical descriptive terms. And in this one, there is a rolled active border. The dimensions look like something like 5 by 3. The base has friable red tissue, and there is some serous crusting on the inside of the raised border, and there are 4 or 5 satellite lesions. And enter and sign in your vote, and let's see how many of you are in line with what this is. And don't be afraid to guess. It is important to participate. Okay, 46% pyoderma gangrenosum, which is the correct answer, and you will get some insights into the other 4 as we go through this presentation. Okay, let's go on to the next slide. So 50% or more of the cases are associated with inflammatory bowel disease, rheumatoid arthritis, myeloproliferative disease. Pathergy means that if you try to debride that active rolled border, you're actually activating the neutrophilic infiltrate. And so what happens is that you'll actually make the lesion worse, and it will actually expand at a faster rate. Do not use iodine dressings or cover with strong adhesive dressings. So you really only want to use the soft silicones, and be careful that you need adequate pain medication for these patients as well. Next slide. It is an autoinflammatory dermatoses. We have limited cases where they don't spread that quickly, and aggressive cases where they really spread and can become circumferential and involve the whole leg from the ankle to the knee in a few days. Some of the investigations are to look at a complete blood count for myeloproliferative disorders, plasma protein electrophoresis, abnormal circulating proteins or immunoglobulins, rheumatoid factor, ANCA in selected cases, and a G workup for inflammatory bowel disease. And sometimes the lesions may herald involvement in the gut before the gut becomes apparent. Rheumatoid factor, you look for deforming arthritis and stiffness in the morning, etc. Next one. Here's a 33-year-old female, blisters on the leg. The lesions evolved over 3 days. There is a history of inflammatory bowel disease, and sometimes these lesions indicate the bowel disease is active and sometimes not. And there's no history of arthritis. Next slide. Investigations, CBC, rheumatoid factor, ANCA, are all negative except for an anemia. Protein electrophoresis was normal. GI workup, it can be silent. And the treatment is treating the underlying cause. Sometimes it's steroids, and it may be topical and often around the edges of the lesions. You can use interlesional triamcinolone. Topical calcineurin inhibitors, they have a limited use of 383. Otherwise, a tube of Velladil or protopic ointment might cost $150. Oral doxycycline, 100 to 100 twice a day. Sulfasalazine, we prefer over dapsone. You don't use dapsone without checking for hemolysis and doing a G6PD. And second line would be oral prednisone or oral cyclosporin. Next one. Here is diagnostic criteria. So up until now, pyoderma gangrenosum was often thought of a diagnosis of exclusion. With this diagnostic category, a skin biopsy showing neutrophilic infiltrate, which is the only major criteria. And it's much more likely if you have 4 of the 8 minor criteria, but you don't have to have them. You need to exclude infection. And certainly on histology, you can check for bacteria, atypical mycobacteria, deep fungus, or unusual infections. And usually we biopsy the edge of a lesion if we're looking for histology. We may biopsy the center of the lesion, and we often use a sterile urine collection bottle to put with just not bacteriostatic, but saline on a gauze and put the biopsy from the center of the lesion for either regular bacterial check, but it may also be sent to the provincial lab for atypical mycobacteria or deep fungus if that comes in to the differential. Pathergy is ulcer at the site of trauma. So if there's a known trauma, that would count. We exclude infection based on a swab or a biopsy or clinical signs. And Dale, clinical signs are probably more important than other laboratory tests.
They really are. I mean, we'd like to keep them in conjunction. Like we work with, of course, everything together, but it's the clinical signs, but also a patient's history as well will be able to tell us a lot about whether something is infectious or not, because particularly where we're looking at pyoderma, it can be so difficult to make that differentiator just based on your clinical signs. But there's so many aspects to it, and really one does need to take a full history and do a full clinical examination to be able to make that diagnosis.
And I think that's important because using these 4 or more criteria, along with the major criteria, the authors, and there were 15 experts who had published in peer-reviewed journals, they found and they felt that at least half the case studies of pyoderma gangrenosum in the literature probably did not fit the diagnostic criteria, and they're probably more likely to be something else. If they've got inflammatory bowel disease, a personal history, or inflammatory arthritis, that would count as a criteria. A papule that enlarges or evolves into a pustule, and then a vesicle. So a papule is solid, less than a centimeter. Pustule is liquid and has pus and superficial. A vesicle is a fluid-filled sac less than a centimeter. And if they rapidly ulcerate or evolve, then that's a second or a 4th criteria. Clinical or photo evidence of a single lesion, peripheral erythema, undermined border, as you saw in the picture, and tenderness. These are often very painful. Photo evidence of multiple lesions, at least one on the lower leg, would count as another criteria. Clinical or photo evidence of a scar, which is described as cribiform or a wrinkled cigarette paper type scar. And the treatment would be a decrease in ulcer size within 1 month of initiating immunosuppressive therapy. So I think these criteria are important to keep in mind. And if you biopsy a late lesion, it'll probably show a mixed infiltrate, but it helps you to rule out infection and other diagnoses. Next slide.
Dr. Sybil, can I chime in for just 30 seconds?
Yeah.
I just want to highlight that, especially as I'm listening to you speak right now, and this is for everybody as well as myself, is often I get lost in a lot of dermatologic phrases and terms and things like that. And what I often tell residents, and this is because they're not doing a dermatology rotation with me, so take those with a grain of salt. I always tell people to use the language that they have, right? If you understand the difference between a bullous lesion and a vesicle and so on and so forth, of course, use it, yes. But if you don't have all those language, because I recognize that sometimes it can be a bit of a barrier for people, use the language that you have, and that's what we are specialists in, and the same thing goes for infections as well. That I think it's so important to be able to describe what's in front of you, as oftentimes what this will be is, a letter that goes out to somebody or over a phone call on that. And you're here, of course, to help gain some knowledge and gain education in certain terminology in that. But I just want to highlight that it shouldn't represent as much of a barrier. We are here to help. And I'm saying this as somebody who's often myself a little bit freaked out by different dermatologic terms.
And I think the other thing is, if you're not sure of the diagnosis, describe it in your terms rather than putting a diagnosis on the chart, which everybody else then follows and believes that's the correct diagnosis. And a skin punch biopsy is really a very easy technique. The nurses that work in our team have the directives and are available to do these types of procedures. It's something that you can learn, and with the proper support within your workplace, you can do these. And cleaning with alcohol, povidone, chlorhexidine, mark the area of where you're going to do the biopsy, put the local anesthetic in. Xylocaine with adrenaline will decrease the amount of bleeding. You'll be able to see that the anesthetic has taken because you get a white area from vasoconstriction of the superficial blood vessels. Put the punch over the area to be biopsied, and you rotate it back and forth until you get up to the hub of the punch. You pull that out. I often use the needle I use for the local anesthetic to lift the biopsy out so I'm not squishing it. If you squish it with forceps, you make the job of the pathologist much more difficult. And you either suture it or you can put calcium alginate. If you've got a bleeder, you obviously need a suture. Petrolatum, double antibiotic cream, or Fusidin or Bactroban. You watch for secondary infection. And in most sites, the sutures come out in 2 weeks. If it's on the face or a thin area of skin, then they may come out in a week. Next one. Okay, so you see, is there a cause? Can you link it to any of the diseases? Do you need to control that underlying disease? You need to make sure you don't have deep and surrounding infection that needs to be controlled. If it's on the legs and you have adequate blood supply, you may need compression therapy because uncontrolled edema will actually decrease healing. Check for metabolic syndrome, the hemoglobin A1C, blood pressure, renal function. You need to adequately control pain, optimize nutrition, remembering that granulation tissues protein, and smoking, particularly in things like hidradenitis suppurativa, pyoderma gangrenosum, leg ulcers, is a pro-inflammatory stimulus and will often make these people worse. Avoid trauma, proper local wound care, and control critical colonization or local infection with something that is at least neutral or anti-inflammatory. For example, silver is anti-inflammatory, where povidone iodine is pro-inflammatory. Next. Limited disease, you may put Protopic or Elidel around the border, or you could use clobetasol, a strong steroid. You can use interlesional steroids or oral doxycycline, 100 to 200. When you start getting limited to aggressive, you might need oral prednisone or oral cyclosporin. Sulfasalazine, we prefer over dapsone, and an equivalent dose is 500 milligrams 3 times a day. You don't use this if they're sulfa sensitive, and you don't use dapsone without checking that they're not going to be susceptible to hemolysis. IVIG has been used, and then in aggressive disease, we're looking at TNF inhibitors, so biologics for Remicade or other biologics. Next one. This is just a comparison of prednisone and cyclosporin, and cyclosporin requires much more monitoring. You have to watch the blood pressure, you have to watch renal function. Even with prednisone, you have to check blood pressure. I usually do a baseline chest x-ray if I'm going to use either of these agents, and it may be guided by side effect profiles of the patients, but in this disorder, they ended up being roughly equal in efficacy. Next. Here's our second disorder. You see this black area just over the top of the Achilles tendon or at the upper area of the gaiter area of the calf is this livedoid vasculopathy, bullous pemphigoid, hypertensive ischemic ulcer, vasculitis, or necrotizing fasciitis. So enter and sign in, please. And some of these terms are terms you may not be as familiar with. But it is important because if you recognize this disorder, you can really help patients. And this may be very important. And let's see the results of the vote. And so it's interesting, 37% necrotizing fasciitis. And we'll show you what that looks like a little bit into this talk, but 35% of you said hypertensive ischemic, which is absolutely correct. And let's look at the next slide. So this is a painful wound with a necrotic base. It's commonly on the lateral dorsal aspect of the calf or Achilles tendon. Hypertension and sometimes type 2 diabetes. Pain is not exacerbated by exercise and leg elevation, so that you know it's not primarily arterial disease. There's diagnosis, history, and clinical confirmed with a deep elliptical skin biopsy, surgery to take away the dead tissue, or necrotectomy, plus or minus a skin graft. Next slide. And this is cleansing the wound, marking the site, local anesthetic, xylocaine with adrenaline, excising the lesion with a scalpel, suturing the defect, and similar aftercare. It's a little bit more complicated to perform than the punch biopsy, but we really need the tissue, the deeper tissue, down to the dermal subcutaneous junction. Next one. And so it is extremely tender. You often get a livido or a net-like pattern around this. The biopsy shows medial calcification of the blood vessel. There is fibrosis in the subintimal area, stenosis of the arterioles, thrombotic occlusion, and because the arteries are occluded, you get cutaneous necrosis. Next one. All right, let's go back one. Karen and Jolene, it's not always possible to take all this dead tissue out, and you really did have a difficult case that you managed quite well.
Yeah, it was an elderly lady that you'd actually seen during a educational session here, during a boot camp, we called them. And Jolene and I carried on seeing her. She wasn't, because of the comorbid conditions, she wasn't eligible for any surgical debridement. So we did bedside surgical debridement. So I would instill some local anesthetic, and we'd take out the plates of calcium that were causing the wound to continue and not heal. And she did well. She tolerated them well. Jolene?
Yeah, the important part was the local anesthetic, because the slide says extremely tender. I often refer to them as wildly painful, because they are very painful. And so people with this kind of wound would not tolerate debridement without some sort of local anesthetic.
Yeah, you can't even touch their skin when they're active, and it really affects any aspect of a normal living condition. Next slide.
Yeah.
Okay, this is a cutaneous vasculitis, and this is palpable purpura. It's most common on the lower legs, where you get the most reduplication of basement membrane because of gravity. There's a slower flow. there's more sludging of the blood vessels and more susceptible to trauma. So this is where immune complexes can be trapped. It's usually bilateral. It can be distal, and this probably indicates a smaller blood vessel involved. Next one. Here you see the one on your upper left, and this is leukocytoclastic vasculitis, so a neutrophilic vasculitis. The one on your upper right is a livedoid vasculopathy. This is where the small vessels end up getting coagulated, or you've got them with a clot in them. It's extremely painful. It'll leave white atrophic scars, so you've lost your normal epidermal appendages like hair follicles and sweat glands. And but the acute lesions are actually ischemic, and so they're very painful. The one on the bottom left is a deeper, medium-sized artery involvement. They're not as discrete on the surface. You can see the necrotic area, but there is a variable amount of surrounding erythema. And about 50% have systemic involvement. And on the lower right side, there is some painful nodules, which could represent, and it's more common above the knee, to have a paniculitis rather than the dermal tissue involved. But certainly there is a nodule there, and there is diffuse but painful erythema. Next one. Okay, Dale, the next three are fasciitis and cellulitis. Why don't you, I think this is probably one of the signs, seeing a cellulitis-like picture that you can't draw a line around, and hemorrhagic blisters.
Yeah, when we're thinking about things like necrotizing fasciitis, you can often draw a line around it because you can often see a differentiator between the area of redness or erythema and the lack thereof. But the key thing for necrotizing fasciitis clinically is that the redness will extend beyond that area of demarcation pretty quickly, like within the next hour to a few hours. The other aspect is that that tenderness, which will be quite extreme, will extend beyond that area of redness, which is really not what you should see with erysipelas or with cellulitis or anything like that. And then beyond that, you're right, we can see bullae here. We can see some of those blisters, but we can see blisters in other conditions as well. I've certainly seen it with cellulitis, with certainly severe cellulitis. And it's notable, though, that you need to take it into account, the gamut of the symptoms that you're seeing in front of you, while keeping in mind that necrotizing fasciitis, which is an infection of the fascial layer of the skin, it's not a clinical diagnosis. It's also not a radiographic diagnosis. It's not a biochemical diagnosis. It is a surgical diagnosis. You need a surgeon to make that clinical, or that differentiation between whether it is or is not necrotizing fasciitis.
Okay, next slide.
So there are a few different types of necrotizing fasciitis. Type 1 or group 1 that you can see here, and type 2. So type 1 is polymicrobial, so it's usually a plethora of different bacteria that are causing the infection in question. And the second type is monomicrobial, so there's usually just one. Now, by far the most common cause of monomicrobial necrotizing fasciitis is streptococcus. So it's group A strep, Streptococcus pyogenes. So group A strep can be very, very severe, and this is one of the more severe presentations that we see of that. But the difficulty when somebody comes in with necrotizing fasciitis is that we don't yet know what it is caused by. So when we treat type 1, we would treat it with something that's broad, that has anaerobic coverage, something that has gram-negative and gram-positive coverage, all of the above. So an option like piperacillin tazobactam would be a great choice. But for type 2, we actually need different antibiotics. We would actually be able to get away with penicillin, for example, for group A strep. But there's always that risk of a resistance in that strain. Notably, we really don't have actually a lot of resistance with group A strep to penicillin, fortunately, but we're especially in a situation like necrotizing fasciitis, we always want to give the benefit of the doubt, and it can be life-threatening. So we do want to deliberately broaden our treatment a little bit. So with that in mind, we don't treat with penicillin, we would treat with vancomycin because we know that there's absolutely no resistance to vancomycin amongst group A strep isolates that we have here. But the last thing to mention about antibiotics, so we've already got tazocin and vancomycin on board, which can be a problematic combo for the kidneys, but that's a story for another time. The other thing that we like to do is we cover the infection because it's so severe with a third agent, and that third agent that we cover is because of something that we call, or to get to something that we call the eagle effect, which I often call the only cool sounding thing that we have in infectious disease. So the eagle effect, unfortunately not named after the vicious animal, but is named after somebody's name. But really what it is that when you have so much or so many bacteria in a wound that they're causing such a severe infection as you would have in necrotizing fasciitis, the bacteria themselves don't divide that frequently. They can sense that there are other bacteria around, so they don't divide as much. And because of that, they produce all the toxin and kill people. But the other thing that they don't do is divide. And beta-lactam antibiotics, so penicillins, cephalosporins, carbapenems, things like that, they all work only at the division. So when bacteria are dividing, and that's when beta-lactams kill. So if they're not dividing, it's not going to kill anything. So what we need to do is add another antibiotic to kill with a different target and bring that bacterial burden back down to a lower level so that you get back into that time of logarithmic growth, lots and lots of division of the bacteria, so that your main antibiotic, the beta-lactams, in this case piperazone tazobactam, can do its job to kill things. So that's the eagle effect. And what we use in necrotizing fasciitis to accommodate or to produce the eagle effect is clindamycin, which if you've been listening to me before, you know I hate. Clindamycin causes lots of diarrhea, lots of pain, lots of C. difficile, things like that. But this is the only time that I really advocate for its use in necrotizing fasciitis. And that's what we do. Dr. Sibold, back to you.
Next slide, one more.
Oh, one more. Oh, it's still me. Sorry. So this is a far less dramatic presentation of a skin soft tissue infection, and I think something that everybody here will be familiar with is cellulitis. Cellulitis is clinically differentiated from many other infections by the fact that you see that erythema, and sometimes it is a little bit difficult to demarcate because as you go a little bit deeper into the skin, you get that haziness of that erythema, kind of like if you put your hand under deeper water, you can't really see where the edge is. When somebody comes in unwell, we usually recommend if they're systemically unwell, fevers, chills, sweats, hemodynamic instability, things like that, that we start with parenteral antibiotics. But the reality is the vast majority of individuals who come into a hospital, into the emergency department, whatever it may be, aren't systemically unwell. They usually have localized infections. It's painful, it's warm, it's tender, it's all of those things, but they're not systemically unwell. So we can usually actually get away with oral antibiotics. But the big key here is that it will take about 48 hours of antibiotics before the cellulitis starts to improve. So I get a lot of patients that come back to emerge, 24, 48 hours later saying, like, doc, you didn't give me the right antibiotic. It's getting worse. That is deliberate. It gets worse over 48 hours. And it's unfortunate. It's unpleasant. I get that. It sucks. But it's also what I would expect. It's almost always gram-positive organisms. There are certainly extenuating circumstances, hot tub cellulitis, which is more often Pseudomonas aeruginosa, something like that. There are extenuating circumstances, but by far and wide, we can use antibiotics that can treat and cover gram-positive organisms. So we usually think of our Staph aureus, MSSA, MRSA, and strep species. So the vast majority of individuals have MSSA and are not colonized with MRSA. And so to cover both of those organisms, we usually start with a first or second generation cephalosporin. I like cefadroxil just because it's dosed only twice a day. At the end of the day, when you see pus, that's where you think more of Staph aureus. Where you don't see pus, you think more group A streptococcus. And I mentioned that for people who are swabbing positive for MRSA, but if you see cellulitis without any wounds, without any drainage, without any pus, more often than not group A strep. And with that in mind, you still would not have to cover MRSA. And I mention that because agents that we have that are oral that cover MRSA well, unfortunately, don't cover strep particularly well. So that's things like Septra, trimethoprim sulfamethoxazole, or doxycycline, which again, they're great Staph aureus agents, particularly MRSA, but poor strep coverers. And that's what we would do. If you do have, to that point on that slide, if you do have a swab or area to swab it, great. But you need to start treatment based on what you're seeing in front of you.
Okay, there's a question.
Yeah. So Darren asked, vasculitis versus vasculopathy are often confusing. Do they have a different consideration and treatment?
Yeah, the vasculopathy usually starts around the malleoli. And if it's just associated with venous disease, it'll be very localized. And we published with Dr. Alavi that if it involves the base of the toes, and you look for the porcelain white areas and the small areas of necrosis and for the vasculopathy. Vasculitis is usually more proximal and not just confined to the distal feet and toes. And it usually occurs in crops, and they're usually palpable purpura. And depending on the degree of injury, it may be itchy, or if the degree of injury is a little bit deeper, it'll burn, and maybe even you might have pain that's nociceptive, so more like a toothache kind of pain. About 50% of vasculitis do have systemic associations, and so ask about arthritis, particularly the knees, and sometimes hands and feet. You ask, and you have to look at kidney and liver disease being common. The lungs, the heart, the GI system, and the brain are less common. But you have to think of those associations. But think of the palpable purpura and a more proximal lesion occurring in crops. The vasculopathy comes on more slowly often, but boy, it can be extremely painful when it's in full bloom. And that's where we sometimes use low-dose anticoagulants, methoxyphyllin, compression if they tolerate it. You might have to start with edema-wear or Tubi-grip and then move up to compression to control the edema, which of course will delay healing. Okay, let's look at the next slide. Here is a patient that developed itchy red hive-like reaction over the legs, subsequently to the rest of the body. The rash has been blistered in the last couple of weeks, and new blisters are occurring every day. So you see some vesicles less than a centimeter and some bullae greater than a centimeter, but you can call them large and small blisters, and Dale will be happy with you. Next one. What's the most likely diagnosis? Bullous impetigo, drug reaction, bullous pemphigoid, contact allergic dermatitis, or shingles, herpes zoster? Okay, let's see what people think. And 44% of you got it right, bullous pemphigoid. Bullous impetigo doesn't usually, Dale, generalize over the whole body. Maybe an infected eczema or atopic. Drug reactions, diuretics, usually often in a photoexposed area. Contact allergic dermatitis, you can draw a line around it, but it could generalize, and herpes zoster is usually in a dermatome. Next one. And the elderly, it is autoimmune. You get antibodies to the subepidermal type of blistering disorder where it affects the dermal epidermal junction. And we look at doing a regular biopsy, and this should be in the edge of a lesion, and the immunofluorescence can be from the adjacent skin. In the immunofluorescent media, the biopsy actually floats, and with regular histology formaldehyde, it sinks. And you can also order indirect skin antibodies for pemphigus and pemphigoid. And if this is active, the IgE level is often elevated. So sometimes doing the IgE level, and this may be elevated before you get a pemphigoid antibody in the serum. Next one. Here's what it looks like if it's partially treated. And this may be more difficult to diagnose, and you do need to rule out infections, but please do not apply topical iodine preparations to bullous pemphigoid. It's pro-inflammatory. This is an inflammatory disorder, so you'll actually make them worse. And the skin is fragile, so putting bandages over this, you have to be careful to think about the soft silicones or non-adherent bandages when secured with cling on the outside or a Surginet type of thing. Next one. Topical ultrapotent steroids, usually you put them on gauze and lay them on. You don't want too thin a layer, it's going to stick, otherwise you need to hydrate it before you take it off. Interlesional steroids, if you have just a few lesions, oral tetracyclines, and the drug of choice, which you'll see shortly, is doxycycline, 100 to 200 milligrams a day. It is a photosensitizer, so sometimes in the summer months, using it at supper, the absorption is only decreased in about 20%, even with milk products, and then a second 100 an hour before bed with a full glass of water. We have the sulfasalazine dapsone type of option as well, but you need a glucose 6-phosphate dehydrogenase before you use dapsone. Systemic steroids, usually 0.5 milligram per kilogram per day. And I mean, I've done this for so long that I know if somebody is 80 kilograms, you're going to start with 40 milligrams. And you usually decrease by 5 milligrams every 5 days and use the doxycycline 100 twice a day as a steroid-sparing agent, although there are immunosuppressive agents like mycophenolate mofetil, azathioprine, and methotrexate that can be used when the steroids fail. And if you're just using the steroids, and you start with 40 milligrams, you may have to leave them on that for a while until you get no new blisters. And it is important to break the blisters, leave the roof on, and count every blister you break each day so that you know what the new blister counts are. Next one. This is an important transformative study. And if you Google blister study in Williams and Lancet, this will come up. Took them 5 years to collect 253 patients from about 50 sites. 132 patients got doxycycline 100 twice a day. 121 got prednisolone. And at week 6, 3 or fewer blisters, 74% in the doxy and 91% the prednisolone. Because they were looking for an adjusted difference, and this has been criticized in the literature, they really saw no difference in the two groups. Related severe life-threatening events at week 52, though, this is where the difference comes. And what you see is 18% in doxycycline. These are older patients, where it was 36% or double the severe life-threatening events. And there were 3 deaths in the doxycycline group, but 11 deaths in the prednisone group. So I think, and even though they all may not be treatment related, I think that it is important to try to limit your steroids. So I do, like I treat acute poison ivy, start with 40 and decrease by 5 milligrams every 5 days. And I happen to know that's 180 pills. If I start with 30 milligrams and reduce by 5 every 5 days, it's 105 pills. And if I start with 20 milligrams, it's 50 pills. And you don't have a label that goes all the way around telling them all the reductions in the doses. Pat, you've had a lot of experience with some of these patients, and they're often not handled too well because people don't recognize this. Let's go on to the next slide. And I think that when we're looking at this, we know about the vascular infection and inflammation as well as proliferative, but the bullous pemphigoid hypertensive ischemic are other things that we should think about, and along with the other infections that you saw as well. And so I think this does give us a good differential for leg ulcer lesions. Karen and Jolene, do you want to comment at all on the bullous pemphigoid? And really, I think it is important to recognize this.
It is important to recognize it because a lot of people treat it with the iodine or inidine, and that doesn't help it. It's pro-inflammatory. So,
and Jolene was just mentioning it's important for everybody on the call to recognize it, because she was just telling me there was a patient with a spinal cord injury admitted that didn't know that they had it, but she was doing a skin examination and found blisters, and sure enough, the patient has been diagnosed with bullous pemphigoid. And we've also had situations where we were treating one patient that was diagnosed with bullous pemphigoid, another patient with spinal cord injury. He had decubitus injuries on his ischial tuberosities, but he had other areas on his buttocks that didn't ever look like blisters, but because of the pressure, he was never off of them. So they just basically, he de-roofed all of his blisters before we could catch them at the blistering phase. And so it was important not to treat those as pressure injury, but to treat them as bullous pemphigoid. So,
okay, yeah, I think it is. It is important, and these patients are often extremely itchy, as to such an extent that they really can't carry on normal function, and that is another clue. And the urticarial lesions, they'll often start with urticarial lesions that are fixed and don't go away, and then they start to develop blisters, and it may be localized and then become generalized, but I think it is important. I think, Dale, you've had a patient or two with this too.
Yeah, I have. I might actually have one right now too. That's that I'm thinking about. And it's really just to highlight that it is. I was consulted because of is this cellulitis, and it might still be. And that's what we're currently working through with our diagnosis. There are bullae and there's erythema that surrounds it, and there's some edema. What exactly is our differential here? And it's hard. I don't want to say, I don't want to make it sound like just because we're on this panel here, I certainly myself struggled with it from time to time. But I previously had a patient that was I would say much more slam dunk, and that it was kind of systemic. It was full body bulle. It was arms, legs, torso. It was everywhere. So that was a little bit more convincing than this one that I've currently got. But it's also a plug for, call your friends, call your colleagues. Like I called Dr. Sibold, and he was able to help me quite a lot to be able to develop a plan for this individual who notably did not have an infection. So that's out of my wheelhouse. So there's that.
Yeah,
There is a
there's
question. Yeah,
Actually,
go
two
ahead.
questions. They're related to topical treatment. So what are your ideal recommendations for topical dressings for bullous pemphigoid? And then there is a follow-up question. Would topical zinc be okay to address itchiness?
The problem with zinc is that it covers up the skin, and it's very difficult to see what the primary eruption is. And because you need a fair bit of friction to put it on, you can use a tongue depressor or something else to apply the zinc. I would much rather see you using something. There is a new red label, CeraVe, that contains pramoxine. And there is a pramoxine HC lotion and cream that are available over the counter. And that is a low sensitizing local anesthetic. And it often provides almost immediate relief. Putting any cream or ointment in the fridge will help. And certainly adding a 0.5% menthol to hydrocortisone or betamethasone 0.05% cream. And it's better adding the menthol to creams rather than ointments because it's the evaporation of the menthol that causes the cooling after application. So you can do that kind of thing. I would rather see people open the blisters, leave the top on. If you wanted to use something as simple as petrolatum, you could. There's nothing wrong with applying a steroid cream on gauze, and sometimes people do use something as strong as clobetasol, which is 12 times hydrocortisone. You might know it as Dermavate, and but you should be careful on the face or folds because it's 12 times hydrocortisone in potency, even though it's 0.05. It's the substitutions on the steroid molecule that make it more active. And on the face and folds, I never go more than 3 times hydrocortisone. So I might go to betamethasone 0.05 rather than 0.1, or Desinide cream would be another example of one that we could use there. There's also Hydravel, but that's the topical steroid that we get the most contact allergies to. And so I tend not to use that cream quite as much.
No.
Was there a second question?
No, that was it. Someone
Okay.
Commented that they have a patient with bullous pemphigoid and they stopped the Inudin use. So that's very good.
Yay. I like that. Now, which case do you want us to present first, Renika?
Whichever. Which Andrew, what number? How have we numbered them? I guess you can go in that order.
That was first.
Zhao's first. Zhao, are you ready? And then Jolene, you come up right after that. And Jeremy, maybe you can text us if you've got internet and connectivity right now.
That I do.
You do? Okay, good. Thank you. All right, Zhao, go ahead.
Okay, so my name is Zhao. I have a patient that called in yesterday that I wanted some advice on, just because this is a wound in a little bit more atypical place than what I usually deal with. Next slide. So my question is that he essentially has an area of undermining that I'm not convinced is healed, but essentially the ulcer has closed over with normal skin on his back. It's currently not filling with fluid as per our conversation, but I can't be sure that it's 100% sealed and closed. The question is, should I reopen that? Should I pull him in to surgically cut out some skin to reopen that, or should I leave it alone and see how it goes? And then he also had some heel ulcers that were from his initial kind of hospitalization, and just kind of any tips from anyone who would on how to prevent them in the future. Next slide. So this is this gentleman's back. Some of the pictures are a little bit off the center frame for me. I'm not sure how you guys see them. So this is essentially on his lower spine. He had spinal surgery in 2023, and he was his primary wound didn't close quite right, so he developed kind of this area here. You'll see in that picture in the middle there that I've tried to outline some of the undermining just to show him what I was talking about, and you could kind of see that it extends on average by 1.8 to 2 centimeters from the openings of the wound. Next slide. So this is kind of just pictures as it's going along. You could see kind of more undermining there, but the wound itself has kind of come down a lot. And once it almost did close, I did debride it because we still caught it with still a little bit of an opening. But now he's saying that it's completely closed. So the skin really wants to close, but the undermining still remains. On his upper back, he actually developed a separate issue. Thankfully, I think it was just an infected cyst that burst on its own. It healed up, and it wasn't a tracking wound from his lower back, as we've had some patients after spinal surgery that unfortunately did do that. Next slide. This was his heel. So the first picture we had was from March, but it actually, when he presented to the clinic the first time, I think a few months before that, he also had this necrotic base pressure injury on his right heel that eventually did heal over time, which is kind of debridement and regular wound care. And he was trying to offload his heel at that point, I think, with a sheepskin in his shoe. He also walks with a walker as well, just to take a little bit of weight from his feet, and also because he's unsteady. Next slide. So this is the wound bed prep, and we'll go through some of these things as we go through. Next slide. So this is a 75 to 80-year-old gentleman. He has a history. He's retired. He used to own a store. He lives in the city. He has cardiovascular disease and a little bit of CHF, actually, because his legs often swell as well. He has high blood pressure. He has dyslipidemia as well as diabetes, generally well controlled. He has had issues with his toes before, like remotely, he said, kind of many, many years ago, where he had them amputated, all of them. Those wounds are healed and has stayed closed for a number of years for him now. We did recheck his vascular supply, given that he had a new pressure injury in his leg, and he does have some diffuse tibial disease on that scan. His surgery is that he had spinal stenosis surgery December 2023. He has no known allergies. He's never smoked. He doesn't use any other substances. I have to admit, I did not specifically ask him about alcohol. And then he has one wound now, previously two. So on the back, essentially what happened was that he went in for surgery. He ended up not feeling great. He ended up being hospitalized for several weeks and then in rehab for a couple months more on top of that. And then when he got out, he had this post-surgical wound that wasn't healing on his lower back, as well as this pressure injury on his heel. On the measurements, I believe, is probably from the last time I saw him. So it has decreased over time. At the last measurement, the opening itself was 0.5 by 0.5. It undermined 1.5 centimeters at 12 o'clock, 1.8 centimeters at 3 o'clock, and 1 centimeter at 6 to 9 o'clock. And that was relatively recent. I want to say that was like last month or so. So it wasn't a huge amount of time ago. There was no temperature difference, no signs of infection at that appointment. And then his heel ulcer, like I said, that did go on to heal. The question here is, how do I prevent it from coming back? Next slide. Medications, he's on amlodipine, which is a calcium channel blocker. He's on 5 milligrams. He's on candesartan, which is an ARB, for his blood pressure as well as his underlying coronary artery disease. He's on clopidogrel for a history of his coronary artery disease, as well as the atorvastatin 80 milligrams. That's a cholesterol medication. That's the max dose on that one. He's on terazosin to help control his blood pressure, as well as tamsulosin to help with his prostate. He's on a whole host of vitamins and stuff that he was told to take in hospital, so he's continued with that. He's on fumus fumarate, which is a iron medication at 300 milligrams, vitamin C, vitamin D3, vitamin B12, and a multivitamin. He also, these were all the medications he remembered, but he couldn't quite remember if there was more, and he never really brought in his blister pack. Next slide. So nutritional screening, no weight loss in the last little while. He's actually been gaining some of the weight that he lost during his hospital visit back, and he has not been eating less than usual for the last week. So these are older, I believe, from March the 1st. That was probably from his back, because it did kind of get bigger on me at one point and it was draining more. So I did swab it, mixed organisms. And like I said, that I can't, and then he also had arterial studies that I talked about before. He does have peripheral arterial disease. He does have calcification, which does mean that when you try to squeeze those blood vessels to get good numbers, it can't squeeze down that well because of the calcification. And he does not have a toe to do toe pressures in. Given that the heel injury healed, I did not feel the need to subject him to CT angio. Next slide. So these are just his pulses, and on a handheld Doppler, he was biphasic. So I do think his spinal, his wound from his post-op surgery is healable, given the fact that the skin does really want to close over and often tries to. I just don't know if it's good enough that I can just leave it. On the foot, to be honest, if I had an area of large undermining and the wound closed, I would generally bring them back. I find that it generally has closed over with callus and kind of other things, and I would reopen that. But on his back, I was just trying to get some opinions from others to see what you guys would do in that situation. Next slide. So with regards to infection, the wound is, I wouldn't say it's non-healing at this point, but it does make some exudate. Sometimes it does become red and friable. And then the only deep criteria he meets at the moment is that it can make larger quantities of exudate at times. Next slide. Footwear-wise, he did have a Darko shoe, but he's actually just wearing running shoes at the moment with, again, that sheepskin on the in the shoe. He did at some point have debridement. For the debridement from the plastic surgeon was that I made a referral to a plastic surgeon to see if they would actually take out that whole undermining at one point, to see if we can get him to heal a little bit better. But we haven't actually heard back from the plastic surgeon yet. So patient-centered concerns, he's actually quite an easygoing gentleman. He doesn't have any pain. He's quite happy that his heel pressure injury has healed. He walks with a walker. His main concern now is, do we leave this thing on the back well enough alone and see what happens, or do we expect something bad to happen and I should do something prophylactically? So here's just more wound information. That's the current size at the top there, and then just a general gist of what's been happening. That cyst on his upper back, I think, was just kind of a unrelated issue to his other chronic wounds. It was just a bit of bad luck, I think, on his part. So his current, his most recent dressing was Vash compress with an AMD wicked just very lightly into the undermining, and then covered with betadine paint and Adine if needed, and a silicone. Well, I actually think that was for his foot there. The packing, he said between dressing changes, which he was getting 3 times a week, fell out. And then by the time he went to his next nursing change, the opening for the wound had closed over. Next slide. So currently people who are involved are his family doctor, Dr. Sybil gets involved at times, the wound clinic, his wound care nurses, and we are still getting an opinion from a plastic surgeon. He had an appointment, but unfortunately, due to some circumstances, that was delayed. Next slide. So again, these are the pictures. That was what it looked like May 28th. So and it did have undermining, of last year. And then next slide. So you could see that it has been slowly closing kind of over time, but still had some undermining on his most recent visit. Next slide. These are the pictures of the heel that has healed up. And I'll tell you what I kind of do now. I kind of actually include pressure injury in the patient's problem list so that when I send them to specialists, when they get referrals, that it's on someone's radar. I also tell patients that when they go into hospitals for unrelated issues, that they should always mention that they've had pressure injuries so that they can keep a better eye on their skin health and try to offload these areas, especially if that's not the primary reason why they went in. But any other strategies from the group would be nice, and he would like some things that he could do to try to prevent these things. Next slide. So Dr. Sibbald, any advice? Should I reopen this thing? Not reopen this thing?
Let's see what everybody thinks. So here we go. Should a closed ulcer with undermining be left closed and observed? Debride the roof and treat an open wound? Perform an ultrasound to identify any additional undermining or connected sinuses, etc., prior to debridement or the next debridement. Debride the roof and create an acute wound in a chronic wound, curette the edge, or ask for a wound consult. There you go. Let's see what they think. Sal, what's his diet like?
His diet is pretty good, actually. He tries to incorporate quite a bit of protein into his diet. His sugars are at target at last check. His appetite is good. And like I said, he's actually regained, he lost about like 20 or 30 pounds when he was admitted, and he's gained a good portion of that back over the last year.
Okay, we are all over the map. Let's see what the faculty think. Kingston, do you want to chime in here? What do you think?
Well, we're split. Yeah, go to us first, eh? I would leave it alone on the premise that as long as there weren't any signs of surrounding cellulitis, I would leave it alone. Because if it's going to, my premise is always, if there's some bacteria there that are going to be a problem, it's not going to stay closed for long.
Okay, Jeremy,
Jolene,
are you?
Got a different
Jolene,
answer.
go ahead. Jolene, go ahead. What did you think? You thought something else.
Well, I was all for looking on the ultrasound to see what was under there.
Okay, good. All right, Jeremy.
Yeah, I would like to know more. I have a lot of apprehension because when in my population, clients, once they leave my office, I have no idea or really control what goes on. They go back to their remote communities. So I'd really like to be super definitive. If there's any premature closure, there's a real likelihood that they could manifest as an infection and sort of come out anyway. If there's a source for that tunneling. So I like to explore and be a little bit more sure, but once it gets so tiny, it can get really challenging when to decide to pull the plug, so to speak.
Pat, do you want to comment here?
Sorry, I'm trying to record the suggestions as well. Jolene, I agree with you and Jeremy as well. I think I would want to do the ultrasound to see what else is going on there. and then probably leave it closed and watch it.
Okay, and all right, and let's see if infectious disease would do anything different. And Dale, what do you think?
So I take everyone's points so far. To summarize, I don't think I would open it up again right now either. I think that I would watch it clinically to see whether it develops any signs of cellulitis, because at the end of the day, if we've got that barrier of against the outside world and the bacteria that are on the surface there, it is protecting the fluid underneath. And if it's just serous under there, and there isn't any contact, and the body should be able to heal that up, I would say, unless it's a huge fluid collection. But is it really that fluctuant? Is it that would be my question about that, I suppose. I don't think that there's anything wrong with an ultrasound per se. I love more information. I love imaging. Lord knows that. But if that's difficult, then I'm comfortable with just a little bit of repeat observation, because Zoo, he sees you on a regular basis, is that right? I know it was a phone call for this one, but is there that opportunity?
Yeah, so he sees me on a regular basis, and then I booked him. I booked him in 3 weeks, I think, just for a clinical exam, just to see if there's anything concerning. I guess my fear generally, and my question comes from, I had another patient like this, and she did close over, and then by the time she came back, she had this tracking sinus of pus all the way up and down her spine, which never closed. So I'm just a little bit leery, but I'm also quite keen on leaving things well enough alone if I don't have to do anything about it. But I am pulling him back for a physical exam at the very least. Yeah.
And yeah, and I think that they might, even if he's got nursing services or somebody, you could spray something like hypochlorous acid, on the area after bathing or showering to try and keep bacterial counts down, just in case there is a little bit of discharge or anything, just to see. But I'd be curious what the ultrasound would show as well. I think I have one more question there for the second part. Go on to the next. Okay, so how would you prevent future heel ulcers if he's mostly bedbound in the future?
Well, I think yeah, never mind. I'll shut up.
Well, look at that. All of the above. Zhao, you've got clear direction when a patient's in bed to do everything. And I think, the idea of using pillows without proper specialized heel offloading devices is probably not adequate. But and it sounds like when he's up and around, is there any pressure on that heel in the footwear he's wearing?
Probably because he has no toe, so I suspect most of his weight probably does go
Yeah.
towards his heel area. He can't see it very well. He's not super flexible. Thankfully, he does have a wife that looks at it for him on a regular basis. He has not yet seen chiropody for a consideration of orthotics or anything like that yet. He's just kind of more concerned about what's going on in his back at the moment, and trying to manage his heart failure, actually. So he has a few other fish to fry for that. His main question was, he never wants another one of those. He thinks they were worse than his toe wound.
Yeah, so I think, being careful with the bed and surfaces is important, along with maybe getting a proper orthotic or insert and making sure the shoes are as best they could be. That was pretty good, everybody. And so, yeah, go ahead, Jeremy.
I just want to add to it for a second. I was thinking about this, and I'm curious if there's any like real evidence of some circulatory issues, like even if like I don't know if you're using compression or anything at this point. And then the other question is about adjuvant therapies, like if this person would have access to something like e-stim, whether the sock or otherwise. Just for the purposes of stimulating additional circulation, and that's a largely avascular part of the foot anyways, right?
Yeah, so for if he didn't go on to heal, I probably would have sent him back to his vascular surgeon to see like if he needed a CTA or kind of other things to get more details. But because he did heal, and his philosophy at 80, like later in life, was to less is more at this point. If he doesn't have to go to a doctor's appointment, he would prefer not to. So because it did heal, we didn't go on to look at further interventions. With regards to your question about e-stim, I know it's supposedly on our formulary. I've never had success with it getting ordered yet. So haven't tried it, to be honest, in our region.
And
I don't know.
Jeremy, one of the problems in home care with the e-stim at the moment is that there's no set protocol. And what happens is patients get a machine that costs $300 and some. They never take it back, and there isn't really the supervision that there should be in home care. Now, I think you'll see each of these things change as the formulary is rolled out and things happen. But at the moment, it's for most home care people, unless there is somebody with expertise in the area, there isn't the kind of guidance that most of the coordinators for each of the health regions are willing to authorize this.
Fair enough. Thank you. One last thing about the compression is just knowing that he's maybe less mobile than ideal. Like some mild compression might support any of the circulation just through those micro movements and some range of motion exercises, for example.
Yeah, but he did heal. He did heal at the moment, so that's the good part. But yes, and with any edema, I think something like the edema wear may be ideal for patients like this, and they can get that on the if they're in home care.
Cheap and effective prevention.
Yeah, no, exactly. Okay, Jolene, thank you for stepping to the plate, and case 70 is all yours. And you'll notice that you have been slightly civilized, but in fact, and Andrew, slide 5 is now slide 6. Okay, go ahead, Jolene. So when you get to slide 5, just pass off, and then it's organized a little bit.
Okay. Yes, it's an interesting problem on a complex patient. So my questions are, should we drain the bulla? And number 2, what would be the best treatment? So next slide. So our management plan. So this is the leg that we are looking at, and the obvious large blister in the center.
Was there an acute trauma?
There was not. No.
Okay.
And she has really tissue paper thin skin. And we've had many traumas on the lower legs, and we've been able to close them all up. But this happened spontaneously. She doesn't remember anything happening. So.
Go ahead.
So she's a 60 to 69-year-old female living in an urban setting. Her medical history, so she's got a pacemaker for tachybredy syndrome. She's got asthma, and she's had a pulmonary embolism in the past. Diabetes type 2, and she also has peripheral neuropathy. She's got gastroesophageal reflux disease. for immune and infection. So she has a history of disseminated nocardia, and she has hypogammaglobulinemia. She has MRSA, that's just a little typo there, and she's got CPO. She also has rheumatoid arthritis. She has chronic pain, and she's had previous spinal compression fractures. She's had inflammatory breast cancer, and that was I think it was like 2017 she had that. And she's had previous pressure injuries, both on her sacrum and on her left heel, and we've been able to close both of those up. Substance use, she has previous alcoholism, and she has no allergies. So for the wound history, she had a spontaneous development of a large bulla with surrounding ecchymosis times a week. So this was a week ago that this occurred. She was sent urgently to acute care to rule out infection, and she returned to us 2 days ago, and this is what her leg looked like when she returned. I didn't see it before she went, so. And Zhao, I'll let you tackle this.
She's on a few things. So she's on insulin, both short-acting and long-acting insulin. She's also on a DPP-4 medication to act on that incretin system to help with her diabetes. She has 3 blood pressure medications. The diltiazem is a calcium channel blocker, will also slow down your heart rate a little bit, as well as the metoprolol there. She's on a relatively highish dose of that. Will also not just drop your blood pressure, but slow your heart rate. Spironolactone is a potassium-sparing diuretic, so it will help save some of your potassium, but help lower your blood pressure. She's on digoxin for her heart failure. And risperidone as a antipsychotic at those dosages, sometimes used for agitation, sometimes some minor things. You could see much higher dosages in some patients who are actively psychotic. Pain medications, she's on a number of nociceptive pain medications, including the acetaminophen. 1 gram QID is probably pushing the top end of safe to take for long-term purposes. We are finding, or most of the recommendations are actually coming down off 4 grams to closer to 3 grams, 3.2 grams, etc. Hydromorph Contin, she's on 15 milligrams every 12 hours. So that's the slow release one. And then hydromorphone, more immediate release as breakthrough. She is using 2 medications for nociceptive pain, including duloxetine, which is a SNRI, so an antidepressant, and as well as pregabalin, 50 milligrams twice a day. Lowish dose there, can move that one up if needed, barring any side effects. Her rheumatoid arthritis is being managed by prednisone, and likely because she's on the prednisone routinely, she's also on Residronate to help protect her bones. She's on 2 inhalers, the Brio Ellipta, which is probably her long-standing control inhaler, as well as Ventolin as a rescue. She's on pantoprazole, 40 milligrams twice a day for acid reflux to help protect her from the prednisone. And she's on a laxative, the Senokot, 2 tablets there at night. Her other medications include a number of supplements, including potassium, thiamine, which is a B1, calcium carbonate, calcium, vitamin D, B12, as well as magnesium. Next slide.
And there was one that was missed on that slide. She's also on apixaban, and she's on 5 milligrams twice a day. And that was stopped at the beginning of the week, but it was recently restarted. So nutrition. So she's not lost weight in the past 6 months without trying, and she's not been eating less than usual for a week. And she is overweight with a BMI of 30.1. Next slide. Laboratory investigations. Zhao, are you okay to take this one as well?
Yeah, so the electrolytes there look normal to me. Her creatinine is normal, as long as she's not bedbound or have other reasons to have low muscle mass. Her hemoglobin A1C is 7.2, which for a patient, given her complexity, I would take. Her CRP is just mildly elevated there. Her albumin is 33, which is slightly on the lower side. Lactate is 2.7. That's actually high. Our hospital starts getting worried once it goes past 2 for concerns of sepsis, etc. So I'm hoping that's on a downward trend, or that's a stable number for her. But that number would actually make me worry just a little bit. Her white blood cell count is elevated. It's 13. Because she's on prednisone on a regular basis, I would actually like to see what a trend is for her on that count. Her hemoglobin is 98, so on the borderline, again, depending on that's going up or down or stable for a wound healing purpose. Her MCV is 88, which is normal, so it could be either mixed disease such as being low albumin as well as low iron, which causes small blood cells, as well as like low B12 causing big blood cells, or it can also be anemia of chronic disease. And given her health history, she could definitely be at risk for her platelet count is normal there. She also has some immature granulocytes, again, making me slightly more concerned about infection. Dale, what do you think about all these lactates and CBCs?
Yeah, I mean, with the CBC, I'm a little bit concerned about infection with the white blood cell count being at 13. So it's 2 points higher than normal, quote unquote. But at the same time, so the lactate could be a whole bunch of things, and I will say, it's not alarmingly high. But having looked at that picture, I mean, the picture itself, I have questions about, if I'm being honest.
I thought you might.
Yeah, I do. I'm happy to ask my questions when the time comes.
Okay, next slide.
I'm looking at her blood work trends right now, and her white count does trend at about 13 or 14, historically, even before this leg. And her lactate does trend a bit high, and they did take her off
It's not going to come to me.
it's not going to, it's the diabetes medication, metformin. Because they thought that was making the lactate high, and it is trending down now. So
That happens. Yeah.
So we'll go to the next slide. And so they did a CT to rule out a necrotizing infection. And they decided in this CT that it was likely a hematoma as opposed to a necrotizing fasciitis. Does that correspond with what you think, Dale?
I mean, it looks like a hematoma, which is good because you could see that on the initial picture as well. When I like the concern so this will contrast with what I said with the last patient. When there's a fluid collection that's a hematoma, there's so much protein and there's so many nutrients in there because of the blood and the coagulated the coagulated blood, et cetera, in there, that it's high risk for bacteria to get in because there's so much food for them in there, as opposed to serous fluid, where it's a lot lower likelihood. And I don't think of it as much of like a nutrient-rich fluid. So it's not surprising to me that they've said that this is a hematoma. It's good to see that there's no suggestion of surrounding, inflammation, necrotizing pictures, things like that. If this was done with contrast, which I can't tell, that would be more convincing to me. But the last thing I would say is, even if it is a hematoma, we do need to be very cautious that it doesn't become infected, would be the last part.
Awesome. Next slide. So for vascular, she has palpable pedal pulses and a biphasic audible handheld Doppler. I didn't do ABPIs because I'm not about to squeeze this leg. And she does wear edema wear daily, but she has not been wearing the edema wear since this started. So she hasn't had the edema wear on this leg in a week. Next slide. So because it's such a new wound, I can't really say it's non-healing yet. There's no exudate at the moment. There's no friability. She does have new skin breakdown because this is new, and she does have erythema and edema. And I did check the temperature on the leg, and there was like a 1 degree temperature difference between the two legs. It wasn't anything significant. She does say that when we're all pressing on it to see if it's indurated, that yeah, that does hurt. So she does have some pain there. Next slide. I'm going to let you comment on this, Dale.
Happy to. So there's nothing that grew in the blood. There's some Morganella in the urine, which we'll come back to, and the wound had no growth of anything, which is not altogether surprising, because there really wasn't anything that looked open to me. Does the patient have any urinary symptoms?
No.
Great. So what we have here is asymptomatic bacteriuria. So provided this patient is not pregnant and is not undergoing any sort of urogenital procedure or anything like that, where we would disturb the urogenital mucosa, there would be no role for treating. Now, we could talk about Morganella a little bit very briefly. Morganella morganii is an organism that naturally has a lot of resistance, which is what you can see in front of you there. And it also can easily gain resistance. It's a gram-negative bug. It tends to be quite fairly aggressive as well. And that's what you're kind of seeing with that resistance pattern there. Interestingly, I'm a little bit surprised that they're reporting out the susceptibilities for ceftriaxone and piperacillin tazobactam, and neither of those are antibiotics that I would actually routinely use for that. I would be more likely to use either a carbapenem or something that was not a beta-lactam, recognizing that carbapenems are indeed beta-lactams, but I would be more inclined to use something that wasn't. So if I'm being honest, none of the options that are there are ones that I would want to use. So I'm relieved that it's asymptomatic right now.
Thank you. All right, go to the next slide. So for pressure, her Braden scale score is 14, so she is high risk. She uses a manual tilt wheelchair with a high profile Roho cushion, and she's up in her chair for approximately 4 hours at a time. And she does tilt back. Her husband is really good at tilting her back on a regular basis. She's on an active power to air surface, and she has her heels elevated off the bed. She does have heel boots. She doesn't like them. She much prefers pillows. So as long as she's not getting any pressure, then that's fine. For footwear, when she's up in her wheelchair, she wears Darko shoes. She did have a previous right first MTP wound when she was ambulatory. She's not very ambulatory right now, so it's closed. But she does still wear the Darko shoes because she is doing physiotherapy. Next slide. So friction and shear, she's currently a mass assist of 2 for transfers. She does a stand and step and pivot transfer using a pole. And she's able to roll in bed with like a minimal assistance times when she can't get right over herself, but she can move around in bed on her own. She does have occasional bladder incontinence and occasional bowel incontinence. She uses a brief, and she also uses a bedpan and a commode. And oftentimes her incontinence is usually due to her lack of mobility and not being able to get onto the bedpan or the commode on time. For mobility, she is weight bearing is tolerated, very limited at the moment. She's working with PT and OT daily on that. Next slide. For patient-centered concerns, so she says that her pain in the leg right now is about a 4 out of 10. Because there's been a lot of us in and out and poking around that, she says it will go up to 8 out of 10 if we're poking too heavily, which makes sense. She lives in an accessible apartment with a very supportive husband. Next slide. So I've classed this as healable if we can get it managed fairly quickly. She's had many areas on her lower legs and feet before from traumas, falls, banging her legs that have all gone on to healing. So I'm hoping that this one will be the same. Next slide. So the wound information, so this is the left lower leg. The size of the blister is 6 centimeters by 6 centimeters. And then the size of the hematoma that was measured in the CT scan was a little bit larger. She's had it for a week. At the moment, we just have it open to air. I haven't done any type of debridement. I'm actually a little bit afraid to touch it at the moment. And it's dry. Next slide. And her management team is herself and her husband. She has nursing, OTPT. She's got a dietitian involved, a hospitalist. She also sees the chronic pain clinic, the cardiac rhythm clinic, rheumatology, and hematology. Next slide. And there is our wound. And so my question is, do we pop it or do we not pop it?
Do you have her on antibiotics right now?
No.
Is
Then I vote
it
not
still
popping.
tense? Like, is it still tense or is it deflating a bit?
No, it's deflated a little bit.
Because my understanding is
Probably, yeah, okay, go ahead.
I was just going to say my understanding is when it's really tense, it can continue to denude underneath, but if it's deflating, like maybe it's not causing further damage. So risk of infection, you have to weigh that.
Yeah, I would probably, because I would worry about it popping and then getting infected. I would
Yeah.
probably pop this and paint it with betadine on the outside just for antibacterial effect, Dale.
If we're gonna pop, I would strongly recommend that we use something antiseptic on it as well. I think iodine is a great option. Yeah, yeah, I'm on board with that. It's safer if the patient is on antibiotics, but I fully recognize that I don't think there's a role for the antibiotics right now either. So I just wanted to clarify that.
After you pop it, it would be nice if you could put some compression like edema on there, and then that could secure a non-adherent or, a cling around there just to have something next to the skin.
Okay. So my other question is this hematoma under there? As Dale said, it's going to grow bacteria in there, and she's super high risk for infection.
Well,
And
that's
so,
why you have the betadine, but if you're really
Yeah.
worried, Dale, when would you use your antibiotic? When you had any signs of it locally, or would you use it?
Yeah, I would watch for a few different things. I would certainly watch for the local signs and symptoms of infection, things like that. And the other thing I would watch to see if the white blood cell count is trending upwards. Recognizing that she's kind of around her own baseline, which is already a little bit high. But I would take it all within that context. That's what I would do.
Yeah, and I think the betadine does have the best penetration locally, and if you have some blood there and two surfaces of different viscosity, then and there were to be biofilms, that would help you more than some of the other agents.
And can I just clarify for our audience, by popping it, you're saying you'd maybe wash with povidone iodine before, you'd use a small gauge needle on the side of the blister to remove some of the fluid. Would you send that for culture? Would it change your management if it came back with anything? And then you just leave it from there and maybe continue to paint it with povidone iodine?
Yeah,
You wouldn't
I
actually
would
deprive
pop it and
her-
culture it though. Yeah, I would culture it because I think, and then if there is an infection, then you have an idea of what it is, but I'd wait for the signs of infection. It's just interesting. She's back on her anticoagulant. Is she on a regular dose or a low dose?
She's on 5 milligrams of apixaban twice a day.
Which is a dose for somebody of her age, right?
Yeah.
Yeah. She's on it for atrial fibrillation.
Yeah, so that's, yeah, so she does need it. I think the compression on the outside would be a good idea, though.
And just in terms of etiology, Jolene and I were talking about this. She's had a previous DVT, and we wonder whether, you know, the previous DVT would occlude some of the deep venous system, and she may have incompetent perforators to a superficial vein, and this may have been a superficial vein that popped. Because there was no trauma or anything.
Yeah, I think that that's possible. Did they check for clot underneath?
No, I don't think so.
I would probably.
Not sure about.
Dale, would you check her for a DVT and what extent it was?
Yeah, I would. And the caveat being that by the time they get to me, they've almost invariably always had ultrasounds and that sort of thing. So I'm not usually the one who's ordering that.
Yep.
I would.
Yeah.
They did one.
They did one, yeah.
Yeah, they did it.
And
It says no evidence of DVT.
okay, good. And then I think that'll resolve better than if you did find one underneath it with a little bit of compression, not a lot.
Okay, so we can put her edema wear back on her then.
Yeah, I think you should.
Perfect.
And there is an increased risk. Good case, good case. And you know, this is a more common than not problem. And with things below the knee and without a DVT, there's no reason why you can't have low compression on, because you don't want edema keeping that clot going for a longer period. Very good. Now we are turning to Jeremy to look at Clinician's Corner. Jeremy?
Alrighty. So yeah, we're going to be talking about cultural safety and wound care today. Can everybody see my slides?
Yeah.
So I'm going to be doing this this session. Usually I do it with Jose, who couldn't be here today, so I'm going to do my best to do her slides justice. But before we get started, I just want to recognize that it's forest fire season. And currently my area in particular is the Northwest is being hit pretty hard. In fact, we actually have a community about 3.5 hour drive east of me that's evacuating to Sioux Lookout right now due to threat of fire that's sort of coming at them. And I think it's really important that we recognize this season because there's going to be a lot of communities that are displaced as wildfires sort of rage around the remote and isolated areas that they live. And so urban communities might have an influx of folks, you know, services are going to be put to the test and those kinds of things. So I just want to really acknowledge and take a minute to just kind of recognize those that are going to be displaced and all of the things that they're going to be dealing with, right? Home and community care issues and all kinds of things. So just wanted to use that time. Thanks. Also, Jose and I usually disclose that neither one of us are Indigenous to begin with, nor are we experts on the topic, but we do consider ourselves allies. And we share information based on the experiences that we've been gifted. So, you know, we also want to recognize that we're speaking to some possibly triggering content. So just be aware of your own needs during this piece. And if you have to walk away, it's okay. Some questions to consider. So I'm going to bring up a little bit about two-eyed seeing. So think about what that really means to you. as I talk about it? And how can we as healthcare providers support First Nations populations regarding outpatient skin and wound management? Jose and I always bring up the 7 grandfather teachings. To begin our journey into cultural safety, we have to first acknowledge our own personal biases. Whether right or wrong, we have them, and we should be able to reflect on them. Then we can start to learn about other cultures and how they influence behaviors and attitudes, particularly as they relate to health and wellness. As an example, learning about the 7 grandfather teachings, they guide our everyday practice when you work with Indigenous populations. Through courage, we can find meaningful ways to advocate within our circles of influence. We respect the practices of our clients and their communities, especially knowing that there's quite a big differences between them. We share wisdom through storytelling of our lived experiences. We stay humble as we celebrate the strengths of one another for the betterment of the group as a whole. Strive to remove ego from the situation and be honest with our failures so that we know how to succeed. We also come from a place of love and will do no harm. And finally, working at acknowledging the truth so that we do not repeat the mistakes of the past. The wound bed prep paradigm, obviously social determinants of health have an impact on all of these different sections, but I'm really highlighting what it means to be a person living in this culture, living with a chronic wound, and what their patient-centered concerns might be, and advocate for some health system change. So two-eyed seeing is a concept that brings together Indigenous and Western worldviews and considers issues from multiple viewpoints. Within educational healthcare institutions, beliefs and practices are often understood and shaped by Western perspectives and science, which tends to exclude or devalue Indigenous worldviews and knowledge systems. By embracing a two-eyed seeing approach, one can result in new approaches that provide key insights into health and well-being of the population. And if we learn to see it through both or multiple perspectives, we can draw from what is useful and relevant from both without one perspective dominating the other. This framework was developed by a Mi'kmaq elder, Dr. Albert Marshall of the Eskasoni First Nation, who describes the two-eyed seeing as to see from one eye with the strengths of Indigenous ways of knowing, and to see from the other eye with the strengths of Western ways of knowing, and to use both of these eyes together. And that belief system is now becoming more and more entrenched in our systems and how we work with First Nations, being able to support each other as opposed to this is the only way to do things. If you do it my way, this is what you'll get kind of thing, right? So you start to see some of these changes at the system level, and over time, things hopefully will improve as First Nations have more of a voice in the systems that they're having to work in. So just to juxtapose a little bit, traditional and Western medicine. This is something that I found that sort of really like spoke to me in a way that I didn't think it would. I am a Western trained registered nurse. I have a master's in clinical science. I'm an NSWAC. I've done a lot of continuing education. So I really am immersed in a Western education and those types of health systems values. But because of where I work and the experiences that I have, I also see the beauty and the benefits of traditional Indigenous medicine. So just to highlight some of that. So traditional medicine is developed over generations before the era of modern medicine, whereas Western medicine was developed in labs through the lens of modern researchers. Traditional medicine refers to health practices, approaches, knowledge, and spiritual beliefs. Western medicine refers to health practices designed to react in response to illness and disease. Traditional medicine incorporates plant, animal, and mineral-based medicines, spiritual therapies, manual techniques and exercises, applied as single or combination therapies. Western medicines are founded in modern evidence-based practice. However, they do not necessarily always include Indigenous representation in those in that evidence, just from lack of representation. And they use inorganic or synthesized methods to diagnose, treat, and prevent illness on a large scale. less focused on overall well-being, although there have been tremendous improvements on a clinician basis, like not necessarily at the institution level yet, but it is coming. There is a holistic approach with traditional medicine encompassing the body, mind, spirit, community, and land. And Western medicine tends to focus on biophysical aspects of health systems. So you can see when you articulate things in that way that sometimes, I would hope many of you still feel a draw towards traditional medicine, maybe even if you're being introduced to that concept for the first time. So lessons of the two-eyed seeing approach. Interdependence and co-learning. We can acknowledge that we need one another and diverse perspectives to address complex challenges in healthcare, education, and beyond. Respect for Indigenous traditional knowledge is a distinct and whole system that can exist alongside Western scientific approaches. Indigenous traditional knowledge has often been devalued or appropriated by Western knowledge without the consent and acknowledgement and involvement of Indigenous people, which makes it the coveting of that and protection of that knowledge so important to the population. Weaving between perspectives, so acknowledging that as we weave together different approaches for a set of circumstances, one approach may have more applicable strengths than another. Knowledge is context specific. Our worldviews are affected by social, political, economic, and environmental contexts. Be open to change by considering different perspectives and ways of knowing when required by the situation. I think we all experienced that through COVID as a personal example that we all can probably relate to. Seek out Indigenous voices. When working with Indigenous communities, reach out to elders or knowledge keepers to guide the engagement, to guide the project, whatever it is that you're doing. With Indigenous traditional knowledge, and it ensures that cultural protocols are followed. There are many of them, and they differ from community to community. Focus on building trusting, equitable relationships. Prioritize the needs and goals of the community and involve them in all stages of the project. And this image you can see here is represents supporting Indigenous clients. So there's a polling question. What are some of the ways we can support the incorporation of traditional approaches to wellness? And then I'm going to give you some examples in the next slides, but curious as to where your knowledge is at. So we've got over half of you have responded, and the vast majority of you are responding the way that I had hoped. So yeah, all of these are options for supporting the incorporation of traditional approaches to wellness. I don't myself need to know how to apply an herbal-based medicine, but I can, and I'll give you an example of one coming up, of how I was able to support a patient who had that knowledge and wanted to work together on their treatment plan. Something like smudging, which is more ceremonial, it's not necessarily an active nursing intervention, but I've had plenty of clients working in a home care setting who, before the visit could carry on, they needed to set up their environment, their spiritual space. And in order to do that, they asked if they could smudge, and I was more than willing to participate. But without the knowledge of an understanding of what smudge is and what medicines are being used and how they're being used and how to respect them, it can be really challenging to feel comfortable and confident in supporting these practices. Flexibility and scheduling. So it's really common for Indigenous populations to be a little bit more nocturnal. And so sometimes the populations that I've supported, if I followed a rigid 8 to 4 schedule, I would have a huge chunk of my morning where I might not be able to be successful in seeing my clients. And so being flexible in my schedule you get to the community, say it's a remote community, and something has happened overnight. So there's a lot of flexibility that needs to be offered within my understanding of a very Western clinic setting that is very rigid and inflexible in those circumstances, and being able to apply that in a local context. So all of the above are right. Where are we at? 5 minutes left, Jeremy. Okay, so traditional medicines, just as an example, a good friend and colleague of mine, Betty Jean, shared this information with me, but Labrador tea or salves are very commonly used, very abundant across Canada, really, and in the Northwest is quite used. It's ingested or applied. It's said to help lower cholesterol, regulate blood glucose even, but you have to be very careful about how you pick it. It's only good to use it when it's furry and golden underneath, not smooth. So that kind of knowledge is passed down generation to generation verbally. You wouldn't see that kind of stuff written in PubMed. It has to be properly steeped and stored in order to be antiseptic, and can be used as a wound cleansing solution. It has anti-inflammatory and antiseptic qualities and is quite abundant in Ontario. Again, not promoting this by any means, because we have to be careful, but talking with medicine persons or working with elders that have this knowledge, you can really find a good way to educate yourself about them, so that you can support it when your clients are asking about it, because they're going to use it when you walk out the door anyway. So here's a story I like to tell, and if any of you are attending the Nurses Specialized in Wound Ostomy Continence conference next week, you're going to hear me talk a little bit more about this. But this is a patient who had a softball-sized heel ulcer. It looks not as bad as it really was in person. She was admitted to the inpatient floor to try and sort of stabilize her wound and her blood sugars and everything like that she was dealing with. I had seen her as an outpatient for years, off and on, maintaining her feet and those kinds of things. And I was referred to come to the med surg floor. I worked in an outpatient program, so on the other side of the hospital, to come and talk with her and make her compliant was the referral that I saw. And so I knew her, and I knew she was very proud of her Indigenous background, was an elder and a teacher, and she really sort of walked that life. And so it was really important to her to have a two-eyed seeing approach to her care. She knew that she was coming into a hospital institution because she needed the help, but she had her own belief system, she had her own values and her own medicines that really helped keep her as long as she had. Like, she wasn't a young lady anymore, right? She had made it this far with the knowledge and skills that she had had. So after speaking with her, it was really, my understanding was that her relationships with the nurses were breaking down. The nurses were coming in and saying, no, you can't use your traditional medicine. We have orders we have to follow. There's the Hospital Act. We have, expectations and licenses and these kinds of things. And so the relationship was deteriorating. She was firing every nurse that, came on shift, and for good reason. So I said, well, what do you want to do? She wanted to put an herbal-based medicine directly in her wound bed. I said, okay, the only thing I can think of that would be a real risk here is the risk of infection. I'm not the expert in that. Let me go talk to the infectious disease specialist. So I talked to Yoko. She was like, she's on 3 different IV antibiotics. I wouldn't be super worried about it if I were you. I said, perfect. So can we go one step further? And she said, what? I said, can you write in her chart traditional medicine as per patient? To take the pressure off the nurses, it's now written as an order. There's a collaborative effort here on our care plan. The patient's going to be happy. The nurses are going to be happy. And what ended up happening ultimately is that her wound started to heal. You got to see real benefit really quickly because she was able to use her medicine as she saw fit. She then permitted us to cover her wound with a standard Western evidence-based dressing. And the two combined resulted in her needs being met and ultimately her foot being saved. So as far as I'm concerned, that was success. Another quick example, cedarwood cream. Cedar is a sacred Indigenous healing medicine, a grounding remedy when mixed with other medicines to assist with grounding the body, calming the mind, providing a sense of emotional security, and strengthening the spiritual connection to the plant medicine. It can be antiseptic, anti-inflammatory, antispasmodic, antifungal, different concentrations and different uses and methods of application. There are cedar bath ceremonies. Cedar is a very, very important and sacred medicine. So I urge you to reach out and work with your local locally available elders, engage, support, and be really willing to exchange with each other. Like if you're being gifted with that knowledge, that knowledge is a very important and valuable resource. So don't take it for granted when you are engaging. Just a couple of important pieces to remember. There are barriers to change. Some of this is very relevant into this conversation. Truth and Reconciliation Committee of 2015 highlighted what we are trying to communicate as essential steps towards co-design of a system that works for the people it serves. Racism still exists today, continues to contribute to everyday interactions with the healthcare system. We've seen evidence of this in the news with Joyce Echaquan, Bill Sinclair, many Indigenous people that have unfortunately lost their lives as a result of this kind of systemic racism. So it's really important that we still talk about it today. History is important. The proverbial we should continue to reestablish or rebuild relationships with First Nations, engaging in co-design of systems that work for their unique needs. For diabetic foot, for example, the majority of folks that I served were in their 30s and 40s and losing limbs, not in their 70s and 80s. So that means they're still trying to rear children. They're still trying to be productive members of their communities and hold jobs and things like that. So these taking a limb it's a different conversation. Not saying that the 70 and 80-year-olds deserve it or what anything like that. I just mean it means something different. It's going to have a different impact. As you learn and interact with people who've experienced directly or indirectly the trauma associated with colonization, and I'm telling you it's real, it becomes really evident in terms of health outcomes. Think of how this dynamic changes the way people interact with their local healthcare systems. If you don't have access to potable, safe water, or the water that you have isn't safe and you can't trust it, how are you going to keep your skin clean and free of contaminants and supple and intact? You know what I mean? We're now witnessing some of that change in the provincial and federal systems, but programs need to continue to work together. Some opportunities for change. It's imperative that healthcare teams understand this unique history and experiences of Indigenous communities. Teams must also include members of those communities as active participants in the services that are being delivered. Focus less on recommending dressings and more on overcoming each patient's own barriers to healing. Okay. Supply chains are important. Access to advanced therapies and technology, I talk about it all the time. It's not super accessible. Treatment for overall health, trauma-focused, culturally safe treatment plans. If you don't get a response in the first 3 visits, don't discharge them. It takes a long time to build a trusting relationship. Okay, those are my soapbox moments, and I think I'm going to end it there. Thank you very much for your time. Miigwech.
Okay, Miigwech, very well done. Okay, this has been a good session. We do really want to hear from you, and if
you're on mute, Dr. Sybil.
Thank you. No, we do want to hear from people.
I cannot hear you at all.
I can hear you. Can anybody else hear me?
Nothing.
I can hear you.
I can hear you.
Yeah. I think Jeremy.
Oh, it's just me. Everyone says they can hear you. So go ahead.
Okay. Yeah. So we would like the people that have not, that are part of this cycle, not submitted a case to at least communicate with Renika over this week, just so that we can line things up and try to help you. And to bring this, we do need your evaluations. We would like to know what you would like in terms of some future directions, and that what you found useful, what you think is missing in your practice. So we would like to hear from each and every one of you. And the more you participate, the more that this is going to be useful for you. And we will leave this on for 5 minutes to try and get you to fill out the evaluations. And I think this has been a great session, and we look forward to your feedback and your further participation. Next week's topic?
It's pressure redistribution.
Okay, it's pressure. It's Linda Norton. And so occupational therapist and pressure redistribution. So have a good day. Hopefully it's not raining too hard wherever you are, or that the sun is out, and we will see you in a week's time. Bye for now.